Hey, GP learners, and welcome to this live stream where you've got me at the moment talking about the NHS Neighbourhood Plan, as it's been called, as well as the Operational Plan and various other news stories that are going to impact what you're doing in general practice as we crack on, as ever, continue to take enhance your primary care and learning. I'm doing it solo for now. Let's get going. Hello, AGP learners, and as I said in this episode, we've got so much content that we're going to be getting through in terms of trying to understand what on earth is going on with the NHS currently. There have been some major documents that have come out in the past couple of weeks that if you've missed them, which is understandable because loads of stuff has been coming out, but also these are significant things that are going to change, I think, what is going to happen with healthcare, particularly in the next couple of years, and may potentially inform on what we might see in the pending GP contract, which is still not out. Although interesting, there are some other contracts coming out right now that we are going to talk about as well in this episode. As you can see at the moment, it's just me solo, and unfortunately, Andy has been held back. So normally we would have gone live on a Thursday. A couple of reasons, and then we were planning to go today. Unfortunately, he's doing what most GPs could potentially and are possibly doing, which is still being at work because of a particularly good reason. Well, not good, but as you can imagine, there's a reason. And he will be with us as soon as he can. But before he does join us, we will hopefully get through some of the other news stories that we've got to cover. And what have we got to cover? Well, loads of stuff. And as I said, if you are joining me live, do feel free to say hi. So shout out there to Peter Holden, one of our local GPs here in Nottingham. We've got a Nottingham story to cover as well in today's episode. So hi to you out there, Peter, and stuff. And we've got some loads of things to get cracking on with. So I think we're going to do that right now. I'm just going to need to readjust my screens a little bit to make this easier. Normally I've got Andy to help me do this. I hope you'll be forgiving with me as we get cracking on some of this. So first I'm going to cover some news stories that come out from friend of the channel and stuff in our news roundup section as we go to Pulse today. The first news story we're going to talk about is a major shakeup that's happening with vaccination payments and stuff, and this is covered by Pulse, as I mentioned, and there has basically been approved plans for changing the way that vaccinations will be done. And this in particular will be going through ICBs directly. So the responsibility of vaccinations and screening has now been officially delegated to the ICBs to manage rather than through a national contract. Now, obviously, this raises many questions in general practice in terms of what will this mean in terms of QOF and vaccinations being done through that route. So particularly in terms of the workload many practices will be doing typically around about September, October time, and obviously the income that brings, because absolutely vaccinating our populations is important, but also that mechanism does provide income to practices where it actually pays for things like staff and obviously work that is done throughout the practice. But effectively, as it says here, the changes approved by NHS England board at the meeting yesterday, which was on the 5th of February, 6th of February, is the commissioning of all vaccination services delegated to the ICBs, commissioning of most components of screening service delegated to the ICBs with exemption of some functions delivered across large footprints, probably things like bowel screening, for example, and commissioning of child health information services retained by NHS England. So this does raise questions, in particular, which screening services are looking to be delegated. So it looks like it is the ones that we retained are the bowel screening, cervical screening, HPV, and newborn blood spots, but other things will be transferred across. So this, I think, is going to be an interesting one that many practices across the whole country will now be keen to understand what this means. There have been some demonstrator sites that they've tried, which have done different trials, and this may be creating vaccination hubs for various different things, whether that may be for particular health conditions, flu in particular. We've seen COVID, we've already seen examples of that happen. But I think it will be interesting to know and understand what this means moving forward in terms of how vaccinations will run. And obviously many practices will potentially be gearing themselves up for their vaccination campaigns for flu for October already, because you kind of have to order them super early, and this may impact some of that and stuff as we move forward. So be really keen to understand how this will be happening locally, and clearly many are concerned as to how this will develop in terms of potentially impact on financial aspects of practices, pending us still waiting to hear about the GP contract. We shall see. Okay, next story that we're going to talk about. So this is one that's obviously I cover quite a lot, and that's talking about AI. So this news story released yesterday is about how doctors are increasingly using AI and seeing the benefits, according to a GMC report. This was based off a study done by asking various doctors, survey of 1,000 doctors, including 173 GPs, talking about how they might be using AI within practice. Apparently, a total of 17 doctors, including 7 GPs, had said that they'd used AI in the past 12 months and discussed the benefits in terms of the impact with the research team. Suggestions of this was helping to prioritize which patients to see, suggestion of diagnostic tests that should be organized, optimizing care pathways, flags risks and potential diagnoses, and highlighting possible prescribing issues or conflicts. I think, from my perspective, that's definitely what AI can do. Some of that can also be based on machine learning and things, so in terms of particularly highlighting possible prescribing issues or conflicts for prescriptions and stuff. That's already existing for many time. But it does talk about some of the risks, so in terms of where the data is going, how the data is trained, for example, as well, and that some doctors still would not follow the advice of AI because they felt that was not appropriate to be doing so. It's an interesting study, and this is definitely a hot topic. If you've seen some of the posts I've put out recently, so I did a session just a couple of days ago at the local LMC conference, and part of that was talking about the use of AI. Really key part, many people are interested to know about. Doing a different session next week at the RCGP North East London session on Wednesday evening. So if you want to come and join me, I think you can't because they're already fully booked. But we're going to be talking about AI and various other parts of tech in general practice. But there's absolutely an appetite for this, I think, across the board in terms of people wanting to understand and know more. If you're watching live, let me know down in the comments what you think about the use of AI in general practice and how it's going to work. Obviously, Scribe AI is the big thing that's been going on over the past couple of months. We've covered that a few times on the channel. Got some more stuff on that coming for you later on. But actually understanding how that will work in terms of other aspects of AI is really an appropriate thing to be thinking about. And I wonder how many people will feel that will have an impact, particularly as we've got many other challenges in terms of the jobs crisis and various other aspects already impacting general practice. Who knows? Anyway, let's talk about another news story that's a little bit more topical in terms of the challenges that many people are seeing in general practice. And this is around some changes in guidance that have come out just very recently, but also impacts that it may have in terms of your prescribing aspects, and that's around the online weight loss drugs. So these are things like your GLP-1s that many patients are increasingly looking at. So things like your Wegovy's, your Mounjaros, etc., and stuff. So there has been a change in guidance that came out just a couple of days ago that basically has insisted that prescribers must independently verify a person's weight or height or their BMI before prescribing medications, and a telephone call or a photo will not be satisfactory in order to do that. So there will need to be some additional information. Now, it doesn't specifically go into what that may be in this particular article, and I've not gone deeper into this to find out more details at this point. But it would be understandable to say that this may potentially looking into more detail to understand what that means for the patient in terms of sharing more appropriate information, and whether that should be done directly through the online provider or whether that will be done via the general practice team and stuff. So that, I think, is going to be an interesting development that we are seeing, and how that will impact in terms of patients contacting services for these medications, which are currently not available en masse in general practice. Obviously, the NICE guidance and that suggests that may be the case soon. So I'm interested to see how areas respond to that demand as it comes through. And me a little bit better now. Apologies on that. It seems I had the wrong mic selected and that was causing problems. So hopefully that should sound a lot better. So you lost the last 2 minutes. Was I talking about GLP-1s? Let me know in the chat down below. I'm going to go on the basis that I just went onto this stuff talking about the indemnity side of GLP-1s. So yeah, thank you, Peter. Yeah, so I get some comments through. Apologies, everyone. It seems I've been having problems with my mic today. So I do apologize. I've switched to a different mic, and that should hopefully now sound a lot better to you all. And I'm going to, crack on from basically talking about
the indemnity aspect of GLP-1s that's come through in this particular article that you can now see on the screen. So this is about how GPs could face legal risks if they ignore the weight loss jabs and information requests that come through. So currently these requests will often come through from online pharmacies, and as a result of that, GPs are then asked to verify potential information or contact the pharmacy if there's any concerns why the patient can't have these medications, because there are safety risks with some of them. But often many people feel that actually that's not an appropriate step to take, because if you're prescribing them, that should be a check that you've done as an independent prescriber to make sure it's safe. That could be taking a decent history. That could also be asking to see the patient's health information through the NHS app, which is available to majority of patients. Or it could be through asking to see their records through other routes and stuff. And that's a decision made by the prescriber, not deferring it in a sense to general practice. Say, well, we think it's safe, but we want you to tell us if it's definitely safe or not, because that is additional work that's underfunded and potentially would be considered access to medical records, because they're not asking for the information of the records itself, and it's not the patient asking for the information, which would be a subject access request in that situation. Having said that, in this article, the MDUs are saying that potentially practices are putting themselves up to risk in terms of engaging or not engaging in this process, and that potentially there should be a consideration of whether that should happen. Now, they do say that GPs have an ethical duty to share accurate and up-to-date information for those providing patient care. However, when they are contacted by pharmacy with information about patients receiving weight loss mode, they can face a dilemma whether they rely on the pharmacy's reassurance that patients are consented to the information being sharing. So there's this question about whether that has been appropriately consented. And then what if that information is misinterpreted, or an incorrect information has been given to the pharmacy? Because let's be honest, many patients don't remember everything that they take. They may not remember every aspect of their healthcare journey and stuff. So, there is a risk that exists there. And it's interesting that the MDU have come down on this, suggesting that there's a risk and that there should be some additional considerations of sharing here. I think as long as practices have a clear process in place, a risk assessment done, and communication back to the providers about why they are not sharing information and different routes to provide that, I think that is sensible and safe. However, clearly I'm not an indemnity provider, and I would not recommend that you follow my particular advice in that situation unless you checked with your indemnity provider as well. So lots going on in those news stories. I'm going to go to the chat now and bring on some of the comments that we've had. Normally I'd have Andy helping me make this as slick as possible, rather than me having to move things around left, right and center to do this. So what have we got? So Ankit Kant, I would highly say that if you do not know the stuff that Ankit does, please check it out. He's got some amazing stuff, including Ankit AI, which we covered on the channel a few months back. More recently, just to mention, Ankit's game that he's created has definitely sparked my interest in terms of certain aspects of coding and things. So if you want to have a play on that on Ankit AI as well, do feel free to do so. It's a little bit of fun and things. And a similar, slightly different version of that is going to be coming from eGPlearning, which is a bit more chaotic in terms of rooms. That's the sneak peek you're going to get. Peter Holden's mentioned that he's been looking at Heidi dictation. AI is definitely the buzzword, but that Heidi bundled with Semble, the system used in private consulting, is actually even more effective and stuff. So there's definitely applications, I think, of AI in general practice. And as I mentioned earlier, the AI scribe aspects are definitely ones that many people are keen and initial to use. There are obviously data questions that need to be answered around the use of those technologies, and quite a few ICBs have said no, some have said yes. I think it's understanding the process that comes into play when it's using AI in general practice, and also remembering patient consent needs to be considered as part of that. But as I mentioned, if you want to find out more, then definitely we've got some stuff on that coming on the channel, as well as we're speaking at a few events in the coming weeks about that as well. Right, let's get back to some more stuff. So me and Andy have come up with this new kind of section that we're calling it the Publications Corner, I think, NHS Publications Corner, based around the fact that we often look at the NHS Publications website to kind of give us an idea of what's going on in general practice because of the releases that it has from there. You may remember how to get to that, and I'm just trying to find it here so I can show you all. So here we go. So this is what it looks like, the publications container, as I like to call it. And I would love it if I had a new jingle. In fact, if you're watching us live, let me know what kind of jingle it should be. I think me and Andy do need to create this. We've just not had a chance to do so yet. But in terms of some of the stuff that comes out, there has been a raft of information that's come out. We're going to get to some of the bigger stories like the NHS Neighbourhood Plan and hopefully the Operational Plan today. But stuff that has come out more recently, and one that I am going to mention just briefly, is the independent mental health homicide review into the tragedies in Nottingham. Now, so those who do know, I live in Nottingham. So this was the unfortunate attack on 3 individuals in Nottingham back in July 2023 by a gentleman called Valdo Calocane, who unfortunately was suffering serious mental health issues. And the reviews effectively found that he was failed by the local services as a result of that. They have mentioned in this particular report that this is a letter to ICBs and mental health trusts and various other aspects, basically asking them to take note of this investigation, and also for the next steps to effectively look at these 5 key things. So in line with your commitment to keep these plans under regular review, we now ask that you review your local action plans, ensuring that they address and identify independent review, particular attention to personalized assessment of risk across community and inpatient teams, joint discharge planning arrangements between the person, their family, the inpatient and community teams, multi-agency work and information sharing, working closely with the families, and eliminate out-of-area placements in line with the ICB 3-year plan. So this is where patients are transferred to out-of-area mental health institutions to be kept in, basically, because the evidence shows that is not great at all. So they have put a time frame of no later than the 30th of June, then these plans should be discussed at the ICB. So it only gives them about 3-4 months to do so for most planning cycles for ICBs, and that they're making a push for these recommendations being implemented as soon as possible. It does link to the actual independent mental health homicide investigation. I have to admit, I've not been able to have a go at looking at that. Even the executive summary is like 30 pages long or something huge like that, with so many findings. So there is a lot to digest there. In addition, you'll notice that there's this, which I found quite interesting, because when I saw it, I thought, oh my gosh, that's the GP contract. It's out and nobody said anything about it. But actually, it's not. This is the standard NHS contract. So this is the contract between other services, i.e. not general practice. And it's a draft version and a consultation of the commitment of what organisations have to do when they're working on behalf of the NHS. It's interesting. I've had a really brief look at it, and I think me and Andy may potentially cover it in more detail in a separate episode. But there's quite a lot, because there's quite a few pages and stuff to go through and things. But this is an opportunity for people, I think, to comment on what the standard NHS contracts mention. And it does, for example, include things like internal referrals between specialities, for example, was one section that I picked up on whilst reading those particular documents. So, they're there. There's various other things you can see, cleaning policies, that kind of stuff, and various other aspects, a step-by-step guide to improving general practice website online journeys. So I think if you think you've got a really bad website in general practice, that's probably a good one to look at. And then a couple of other ones, which includes the 2 stories that we were hoping to talk about, which is the Neighbourhood Health Guidelines and the new operating model to support your high-deliver care for patients, and including the operational guidance for the NHS. So these are 2 documents that came out a couple of weeks ago, which we will be looking at in a second. Interestingly, the one I'm just going to mention before we get on to those is this one, the 2025-26 NHS payment scheme consultation. So it took me ages to figure out what this is about. I thought it might be they're bringing in charges for the NHS, but they're not. They're just talking about the actual payment mechanisms. And what's really confusing is the acronym is exactly the same as property services. So we've got NHS PS, which is payment scheme, and NHS PS, which is property services. Seriously, they need to come up with better acronyms, don't they? Anywho, let's get talking about neighbourhoods. Why? Well, neighbourhoods is the new buzz term for this year, and potentially, I think, where we will see some of the transition for our pending GP contract and the impact this will have on general practice. In particular, if we're looking at this, so if we go to the publication container, so let's switch back, shall we? Let's go to this, which is the Neighbourhood Health Guidelines page. So it's not huge. It's big. It's not massive, and it's broken down as a website, so I think you can access this as a PDF elsewhere. I've seen similar versions, and definitely if you want to check out an abridged version, check out friend of the channel, Tara Humphreys. She's done a couple of blog articles and stuff on it and things. But effectively, I'm going to try and go through this one because I spent more time reading this one. Andy read the operational guidance, so I'm kind of hoping he drops in to join us for that because I haven't had a chance to read all of that in detail. But the Neighbourhood Health Guidelines is basically the government's new approach to what they are planning in terms of delivering healthcare over footprints in the coming year. This is on the back of various other documents like the Darcy Review, and in particular mentions key things that we've heard before. So analog to digital, hospital to community, and treatment to prevention. Just bear me a second. So unfortunately, it looks like Andy's going to be delayed because he's still stuck dealing with some patient care aspects. So we will probably just cover the Neighbourhood Health Guidelines and then leave the operational plan, if that's all right with everybody, just because I don't think I've got the capacity to deal with all that in one go. But we will see. If you're here with me, eGP learners, it may still be possible. And so far, I've got 80 of you joining me live, so I am loving the support. So definitely shout out in the comments if you want as we go through this document. So there's absolute recognition there's need for transformation in terms of what happens. And this focus on neighbourhood health, as it says, reinforces a new way of working for the NHS, in particular linking various different aspects, and is probably a precursor to what's going to be coming out shortly, which is the 10-year health plan. So this is the government's plan for how they're going to deliver healthcare in the longer term. And that obviously, I suspect, will feed into a lot of the stuff that we're going to hear in the new contract when it eventually comes out. It repeatedly makes reference to 6 initial components, and I'm going to come to these in a second, but these are the components that the government currently and NHS England currently feels is the key to neighbourhood health. So remember that, because these 6 are the ones that are initially being asked to be looked at and then expanded upon, and with that keeps these 3 tenets of, and you've heard these buzzwords before, hospitals, community, treatment to prevention, analog to digital in terms of healthcare. The interesting thing about this, it weaves itself throughout all the various different aspects that come. So it talks about the plan to reform elective care. So this was the document myself and Andy covered a few weeks back in terms of the elective care fix, shall we say, and how some of that plans to be delivered. And the key thing he's talking about is the NHS app. So there's real direction that the NHS app is going to be the doorway for a lot of healthcare moving forward. It talks then about what the different aspects of the healthcare systems of primary care, social care, community, mental health, acute and wider system partners will need to work closely together to support people's needs and build support across the existing teams, such as primary care networks and provider collaboratives and collaboration with the voluntary community, faith and social enterprise sectors. So basically, using the established services along with those overview services like the PCNs and collaboratives and that kind of stuff to then support community-based aspects as well to deliver care. And they say that this already happens, but it's talking about how the fact that the system, so the ICS, needs to support this moving forward. How is it going to do that? Well, effectively, they set out a plan that for the next 5 to 10 years it's going to happen, and it's focused on this particular diagram. So the ask for the next year or so is to focus on this initial blue circle, which is the NHS and social care working together to prevent people spending unnecessary time in hospitals or care homes. That's the focus for the next year or so. If you've maintained that, then to look at strengthening primary and community-based care to enable more people to be supported closer to work to home. So, for example, providing more support for those in the community. And then finally, connecting people accessing healthcare to wider services and third sector support, including social care, public health, and other local government services after that happens. So this spreading of healthcare and stuff and things is real to that. And then by doing that, they hope that that will have an impact. Why? Well, there's a recognition that 1 in 5 GP appointments are taken up for non-medical reasons. I would definitely agree with that. There's, a good chunk of the time that I see patients is because of things that is stuff I cannot control or help them with, and actually stuff that's done to them rather than that they have done and stuff. And then, it talks, for example, such as loneliness, housing, debts, and various other aspects and stuff. And actually, if we can tackle those in a different way, and well, why have they happened? You could argue that's down to the loss of the family nucleus. You can talk about the fact that that's down to significant changes in the way that society now views itself in terms of Amazon culture. So everything should be available to everyone instantly now. But actually, it's just a progressive change that we've seen over time. And the reality is that general practice is not designed to fix those problems. But then, could other parts of the sectors support that? Probably, maybe. We shall see. It talks about using various different aspects then moving forward. So, where were we? Yeah. I mentioned other plans. So it does mention the operational plan, which you can see here, and then also the Better Care Fund policy framework, which fits into that. And that's in advance of this one, which is going to be, I think, the big one that determines healthcare, which is the 10-year health plan, due to come out next month, I believe. It was the original time frame for it. Anyway, what does that mean? Well, it says about starting to make a delivery on this, backed off things like the fuller stock take, which we've covered, and various other frameworks like the intermediate care framework. And it focuses on the standard 6 core components for existing practice to achieve greater consistency of the approach. Then bringing those together in an integrated offer, and then scaling up and then evaluating the changes to see which parts have worked well and which parts haven't, and then focusing even more on those and going through that cycle. So the obvious question is, what are those 6 core components? Let's have a look. So this is the appendix. So me and Andy often tell you that the appendix hides all the detail. That's definitely the case in this particular document. So the initial 6 core components, it talks about what you need to look at. Core component number 1, or A, as they call it, population health management. So this is basically looking at various different aspects of data sets to focus on what you need to do in order to help populations. Well, what does that mean? So it's using general practice data, community health data, mental health data, acute and social care, and public health data. And those data sets should inform and support the drive and what the systems in particular are looking at. So applying a single consistent system-wide population health management method to the ICB analytical platforms to segment and risk stratify populations based on complexity and forecasted resource use. So going deep in the data. And if you've attended any of my talks recently, you've heard me talk about how the fact that data is key. Definitely the case looking at this and stuff. And then using intelligence to inform decision-making process. There are other aspects that feed into this. So some of you may be aware of the reasonable adjustment digital flag standard that's going to come through, already coming through and being asked on by practices to look at. And this is to inform how patients will be accessing what support they need to access healthcare. And that, the functionality should allow that to happen, including this cool word that we've been talking about for ages. So integration of systems. Still not there in 2025 yet, are we? But who knows? We may finally get there. We shall see. But yeah, basically focusing on population health management. So that's number one of the 6 core things. Number 2, modern general practice. So for those of you who thought that modern general practice was a buzzword for the past 2 years and it was going to disappear, it's definitely here, and it's now part of the core neighbourhood health plan in order to deliver the outcomes for the NHS moving forward. So ICBs are asked to continue to support general practices with delivery of modern general practice model. So this suggests that things like the CAPE funding that we've had for the past year or so are either going to continue either in its current form or in a different form moving forward, I would surmise from that statement, because otherwise they can't really say they're going to focus on modern general practice without the resources to support that continuing forward. May get rolled in, but we will see. But it does focus on that being the priority. So that's those things like cloud-based telephony, online digital access, and data-led care navigation. It does also talk about pharmacy first, and we've heard recently how NHS England have been a real push for pharmacy first to be prioritised to be used, and also using self-service options such as repeat prescriptions through the NHS app, which we know are high value items, if they can be done for patients to self request their medicines, for example, that can have a potential impact on services that we have. It then also talks about how carers should have the ability to access services equitably in different ways. So patients and carers, sorry. So in terms of the patient should be allowed online, telephone, or in-person consultations, and that the systems should enable that to work more effectively. This bit I quite like. There should also be structured information gathering at the point of contact, regardless of the contact channel, and clear navigation and triage based on the risk and the complexity of needs. See, that to me sounds like a total triage system. I'd love to know what you guys listening to this right now think, whether you agree with me that that particular system suggests total triage as a model for delivering healthcare or not. Let me know what you think in the chat down below. So staff should also have access to structured information about the complexity of the presenting complaint and need. This information should be organized alongside population segmentation by age in particular, and risk stratification information to a single workflow. So this will allow staff to navigate and triage the needs safely and fairly, including enabling risk balance, prioritization of continuity care, blah, 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 all that kind of stuff. So basically driving through the assessment of the need for patients first. So I've got some comments coming through. So Peter Holden, who is amazing in his knowledge of general practice and far surpasses my own, I think, it is total triage. So there we go. Words of wisdom I absolutely agree with. Next, it's talking about standardizing community health services. So making sure that they provide a vital role in the ongoing aspects of care. And they should be developed with a view of supporting people with their physical needs and neurodevelopmental services for children and young people as well. Recognize that people have physical and mental health needs, as well as other aspects like drug and alcohol dependency. It does mention about the mental health additional roles reimbursement scheme. I have to admit, locally, we've struggled to engage that service fully. We have a mental health nurse working in our network, and she's amazing at what she does. But the fact that we can only find one has been a real dampener. And I've been very public in my comments that actually, if we'd had access to that as a role from the start of PCNs, I think we would have a completely different situation. But unfortunately, that's been a challenge. And also, it does talk about joining up mental health services and mental health support teams in schools and further education. And I think there is definitely this perspective that mental health teams need support to hopefully deliver a different type of care, because what we're doing right now, just let's be brutally honest, is not working. Section 4, or D, is the interesting one that many people have raised questions about, which is this neighbourhood multidisciplinary team. So moving away from multidisciplinary teams just within the practice unit, but focusing on this being as part of the neighbourhood area. And one interesting thing, nowhere in this document does it quantify what a neighbourhood actually is. There isn't any detail on what counts as a neighbourhood. So neighbourhood could be potentially a practice. It could be a PCN. It could be multiple PCNs. It could even potentially be a place, or even, I guess, an ICB, if you really wanted to consider it. It's hard to quantify what it is, and I haven't found anything that says what a neighbourhood is in these documents, but I'd be keen to know what you think, and I suspect we will probably have more detail on that when the contract eventually comes out. But in terms of other aspects it's talking about is leaning on neighbourhoods and community services to help in terms of the coordination of care, particularly for those with complex health or social care needs, require support from multiple services and organisations, and looking at deliver proactive planned and response care to support those. Footprints should be designed to optimize neighbourhood working in partnership with local authorities, possibly around the local authority footprints, we shall see. But again, it doesn't specify what they have to be. So there's no actual criteria on that. It does talk about holistic needs assessment, personalized care, planning, social prescribing, for example, as well. Teams could include GPs, specialist nurses, or consultants such as specialist nurses, dementia, secondary care clinicians, including pediatricians, geriatricians, district nurses, GP nurses, acute hospital care consultants, allied health professionals, mental health professionals, social prescribing link workers and social workers, and care home staff and residential care home teams, and members from the VCFSE sector. So basically, everyone and anyone involved in basically a form of community healthcare, as well as some of the specialist care teams and stuff. It doesn't mention about using care coordinators, so I think this is a great time to be a care coordinator. It looks like you can be in high demand moving forward, but let's crack on. So number 5, or E, is the integrated immediate care with a home first approach. So this is focusing on different aspects such as step up and step down beds and virtual wards and stuff to help manage care closer at home, and delivering this to basically try and prioritize and reduce the amount of time patients spend in hospitals. Then last one talks about urgent neighbourhood services. Now this is interesting because this is one thing that we've seen locally within Nottingham is, for example, the development and focus on something called an urgent community response team, which is supporting practices to help deliver care and prevent admissions, hospital at home that we mentioned, which is the virtual wards, and then also focusing on streamlining things such as urgent treatment centres and same day emergency care as well. So I think we will continue to see some of this as well. It talks about paramedic provision as well as other aspects as well. But those are the 6 key areas it's talking about. So just to recap those in totality, we have population health management, we have modern general practice, we have standardising community healthcare services, we have neighbourhood multidisciplinary teams, we have integrated care, immediate care with a home first approach, and then finally we have urgent neighbourhood services. So remember that those are the 6 key initiatives. So the standard 6 core components of existing practice to achieve greater consistency, and the plan is to bring those together across a neighbourhood footprint, whatever that might be, and then gradually scale that up over the next 5 to 10 years. And then with that, rigorously evaluate to see what's working to then focus that. So then it makes it more effective. How do we do that? Well, that's what the next part of this document then talks about, which is effectively focusing on the Parkinson's principle, Parkinson's law. So I think I've got this right. No, Pareto principle. Apologies. So I talk about this quite often, the Pareto principle, which is effectively where you focus 20% of what's going on ends up creating 80% of your actual workload. Now, they've got different information here, but it's a similar concept that effectively the cohort estimated around 7% of the population is associated with 46% of hospital costs. So that this concept of a small proportion of patients actually has a lasting impact on the resources being used. And that's understandable because these are patients with complex health needs that actually use and need more resources in healthcare in order to deliver their care. So effectively what you can then do is if you target to impact those patients, then that's where you can have significant compound gains in terms of how you can then maximize care and also make savings and stuff. And it basically says they want to focus on approximately 2 to 4% of the population. This does bring back hearkening of the unplanned admission stairs to some degree in terms of the numbers and stuff. But effectively, it's asking to look on 5 different cohorts. So adults with moderate or severe frailty, physical frailty or cognitive frailty, for example, dementia, people of all ages with palliative care or end-of-life needs, adults with complex physical disabilities or multiple long-term health conditions, children and young people who need wider input, including specialist pediatric expertise into their physical and mental health and well-being, and people of all ages with high intensity use of emergency departments. So these are our high frequency contact patients, both in primary care, secondary care, and wider than that. And effectively is then looking at how you can do things to try and support those patients as the best as possible, including avoiding their deterioration, streamlining their access to the right time to care, maximizing their use of community services so it's provided closer at home, reducing their A&E attendances because we know that those patients being in A&E generally is not the right place for them to be, avoiding their long-term admissions because, again, that's not probably the best place for them, reducing health inequalities, so tackling those where there's challenges in provision and improving the experience and stuff of care as well as connecting the services and improving the staff experience, which is nice that I think of the staff as well. It does talk about how you might potentially look at doing that. So joint leadership, it talks about accountability, it talks about professional leadership and management and process changes and stuff that would maybe be needed. And then learning from that work to focus that, as I mentioned earlier, and then develop it further. So the summary for the 25-26, so this is probably the key part for many people to be aware of, is apply a consistent system-wide population health management approach. So this is based on stock take, based on core 25 plus 5, sorry, core 20 plus 5. And then using that information to design and deliver services that are most appropriate for that particular patient cohort. And then utilizing, standardizing those 6 key elements we talked about before. So again, population health, modern general practice, standardizing community services, let me get this right, neighborhood MDTs, care closer to home, and urgent community responses to try and deliver this whole mechanism to our patients effectively. I mean, that is massive in terms of the change in direction that we're going to see in terms of the footprints and stuff. It does also talk about how, in order to deliver that, you're going to need potentially some things like a single electronic healthcare record. Come on. We've been hearing about this for years and it's still not happened. And care coordination function between the person, the care, and the wider teams. I think that can really be impactful if it's done correctly as well. And then using different aspects to help and stuff. And not forgetting that health inequalities need to be tackled as well. And this includes getting the basics right. So ensuring that services are accessible to people with disabilities, for example, and those who need reasonable adjustments, engaging the local communities to design the services more effectively, and assigning population demographics, outcomes by population demographics, such as deprivation, age, ethnicity, disability, etc. Doesn't talk about resources to help. Unfortunately, that's not what it mentions in this document at all. And I think that's the missing part for me that I've not seen in this particular document. It really would have been useful if they had done that, but they haven't. So, okay, we're at. It then talks about how ICBs can help. So improving collaboration with effective ways of working, agreeing commissioning models and new funding flows and contractual mechanisms between NHS and local authorities, workforce planning and development, evaluation, and exploring the use of neighbourhood buildings across all partners, including local government. So it's trying to tackle various different aspects of this. So looking at estates, looking at breaking down barriers, looking at commissioning resources based on what needs and stuff. There's some good stuff, I think, in there. The proof, as ever, will be in the pudding and how this will work and stuff. And they're planning on releasing some case studies and things to help showcase good practice. But we will see. So that is the neighbourhood plan. And just as we finish talking about that, I'd be awesome to say thank you to all the eGP learners who've joined us. We've got over 100 plus live viewers currently, so 111 at this moment in time whilst I was going through that particular document. So you all must be wanting to know loads and loads about neighbourhoods. But let me know in the chat down below what you thought of the neighbourhood plan. As I mentioned earlier, this is just one part of the puzzle. The other part is the NHS Operational Plan, which is, I'll be honest, it's huge. It's massive. How big was it? Okay. Okay, so it's not as big as I thought. No, I've just got the summary. That's why. The summary is 19 pages. So that's, I guess, saying something and things. Can we do this? I'm sorry, eGP learners. It's just, I think it's beating me today. Andy does apologise. So he's just sent me another message. He really apologised to eGP learners not being able to make it, but he is at the coalface helping patients and stuff. And unfortunately, he's just been delayed and things. But what I think we will do, we will look at the operational guidance for you and cover that in a separate episode, hopefully, to go through how that's going to impact things, because it does have an impact. I guess just briefly, there's my notes I had on it. I did have some, but I think I've lost them. Here we are, got them. So the main ones I did pick out was the fact that ICBs are to support general practices to improve access to patients. Yeah, we always hear that, don't we? Focusing on digital in particular, and action plans need to be in place by June 25. So I think there's going to be some aspects there. And also in terms of contractual oversight that we may see in terms of the operational plan coming through for ICBs. It does talk a lot on terms of digital access, including using the NHS app and health records. And it also mentions service improvement as well. Dental care comes up quite often, and the need for stress for attendance on budgets, but also some consideration of workforce and staffing reviews as well. So that's the basic parts in relation to general practice, but obviously that document does cover far-reaching other aspects as well. So what we're going to do now, I'm just going to do a quick summary for you all in everything that we've just covered. I know that's absolutely bonkers, isn't it? But let's have a go at it, shall we? So this is the summary of the episode that I've just done in the past 45 minutes or so. So initially started with a news roundup, which talked about the various different news stories that we picked out from latest things, including the vaccination changes. So as of yesterday, the NHS England have approved that vaccinations and screening will be delegated to ICBs to deliver moving forward rather than done on a national framework. Obviously, this potentially has benefits in terms of care closer to the local populations in terms of need, but it does potentially raise the question of how those services will be commissioned moving forward and what impact this will have on general practice in terms of, for example, QoF-based delivery for vaccinations and screening and stuff. Are we looking at vaccination screening centres outside of general practice to deliver this care, and what impact will that have on the financial aspect for general practice as well as patient level care? Will they have to go further, closer? Who knows? We then covered a news story talking about the use of AI by clinicians and how they are seeing the positive aspects of it, but recognizing the data security aspects as well and the concerns that may hold. Then talked about the weight loss drugs, and particularly two news stories that came through that. One, the change in guidance came out yesterday in terms of now data needs to be collected in a synchronous method in terms of BMI data that has an impact in terms of the ability for the prescriber to issue a prescription, particularly through online pharmacies. But then compounding on that is a separate article that came out talking about the indemnity risk of practices who do not engage in that side in terms of checking with the providers in terms of whether or not they have the correct consent process, but then also should they be sharing information on patient safety as well. So well worth a listen to that particular section. You can have a look down below. I'll put the timestamp so you can go back and have a listen to that. We then moved over to our NHS publications corner, where I covered some extra news stories, in particular a review of the mental health guidance that came through out of the Valdo Calocane issue. News story, sorry, my mind's gone there, in terms of the mental health reviews for Nottingham in particular, being a local story. And then talking about the Neighbourhood health plan that came out just about a week or so ago, major plan that potentially has impact, I think, particularly in what general practice will need to do, which focused on the change in direction I think the government has in terms of footprints and what people will need to understand about how healthcare is going to be delivered, particularly in 25-26. As part of that, looking at a focus on keeping patients out of hospital and those 6 key aims, which is population health, modern general practice, standardising community health services, neighbourhood MDTs, so no longer practice-based but neighbourhood-based MDTs, care closer to the home in terms of things like step up and step down beds, and then finally urgent community response aspects in terms of community response and other aspects of care that will help patients potentially stay at home. And there's a big focus there. All of that twinned with aspects of support, focusing on the high index users, and the NHS app is repeatedly mentioned throughout all of that. We then briefly covered the operational guidance, which myself and Andy will probably cover in a separate episode. But I hope that's been a useful episode for you all in terms of covering what's going on. I would like to mention, if you are still joining us, like the 100+ live viewers currently are, absolutely let me know what you think down below, because I've been talking for nearly 50 minutes now solid, and the audio improved partway through as well. But also in that, do check out some of the stuff that we've got coming up soon, including PCM Plus 25, which is selling out quickly. I believe we're about 40% of the way through the tickets, and we've still got 2 months to go. So I suspect if you haven't signed up by the time me and Andy cover the GP contract, you might not be able to. And what we'll be covering that event? Well, the GP contract in its detail as well, how you can tackle that, because we know it will be out by then. It has to be out by then because it's the 23rd of April. But also, what does that mean for your network? What does that mean for your neighbourhood, which is going to be the new term as well, and various other aspects as well. And if you want some cool stuff coming out, then definitely sign up to the eGPlearning mailing list, which links to that will be down below as well, because I've got some cool things coming out in the next couple of weeks. Make sure you subscribe, and as ever, I'll be here to help take hands to your higher weekend learning. Hopefully Andy will be back with me. We'll catch you next time.